Thank you, Neil. It's interesting going forth, seeing how everybody else has approached it. In stark contrast to Barney, I'm going to talk about quite a few papers, and maybe reflects there aren't any one or two outstanding published in the last 10 years in the BJS. Maybe we can discuss that at the end. After a couple of false starts, I felt the appropriate and the fair way to go about this was actually sit down in front of the computer and look, at least at the contents pages of the whole 120 issues of the BJS in that time period. It was actually the decade, the noughties. To look at the abstract of every paper, actually 160, which isn't that many actually, and on the basis, high quality papers, potential or more than the potential to inform and influence practice. After the 4.5 hours or so, I had 50. Didn't plan to have 50, I had 50. I thought 50 was a bit too much, certainly much more than Barney's 1, so I cut it down to 30 without further ado. These are the first 15 of the 30. I don't expect you to read these. Well, some people in the audience will be looking for their name, won't they? Where's my name there? Yeah. This is, of course, as everybody realizes, an entirely and hopelessly subjective process. Can't be anything else. I think it's fair to say that the one area of OG surgery I don't personally get involved in is bariatric surgery, and maybe because of that, I've been unfair on bariatric surgery. I've talked to my colleagues who do it, didn't get any sort of clear answers. There's one paper up here. But if bariatric surgery is underrepresented, I apologize. There actually isn't that much in the BJS. These are the second 15. The top bit's basically anti-reflux, and then some minimally invasive stuff. And then the bottom, some miscellaneous papers. I don't want to keep this up too long. It's for the record, right? I don't expect you all to read this. And obviously I'm going to pick out some of these papers in a bit more detail. But first, a little digression, which might be considered controversial, but I think it's reasonable. It's the paper from last year in the BJS. As you see, a robot-assisted thoracoscopic esophagectomy. Just a report of a series of patients, only 47. Interestingly, the 16 highest risk were excluded. They were done by another method. This should be a pre-selected, good prognosis group. And all the endpoints are there. I'm not going to go through them. You can read them. I think the in-hospital mortality at the bottom is reasonable. In this day and age, it's not great. I think the pulmonary complications I've starred because their definition was a bit harsh, that we can forget that. But the rest of the endpoints are, I'll be careful what terms I use here. I'm being videoed, but they're not good. These are not good results. They compare poorly with published evidence from esophagogastric centres around the UK and the rest of the world. So why am I talking about this paper? Well, I don't think anybody would be persuaded by these data to do this operation, but it might be persuaded not to. That's the point. And the importance of published evidence from a negative point of view is every bit as important, surely, as more positive evidence. Anyway, no more papers like that. Like Jonathan, I'm going to have a few themes, and in the themes I'm going to have a few honourable mentions, very quick mentions, and then pick out one paper in each area. Anti-reflux surgery took off in the 90s, the decade before last, when laparoscopic anti-reflux surgery first caught on. Explosion in this intervention. The last decade's been more of a fine-tuning. Mr. Booth and Tom Damon, these authors from Utrecht, have looked at anti-reflux surgery in the acid-sensitive esophagus, which means a patient with a normal or physiologically normal 24-hour pH profile, but symptoms, and crucially, the symptoms correlate very well with low pH on monitoring. These patients do well after anti-reflux surgery. Improved results in revisional anti-reflux surgery, always a major undertaking. Shouldn't do this without a lot of thought, but with better assessment and usually laparoscopically much better results. Multi-channel impedance pH monitoring. This offers almost certainly a better way to assess quantitatively our patients with the reflux, both acid and non-acid reflux. And I think, like many people, I think the key to success in anti-reflux surgery is better patient selection. And then lastly, the ability to repair large hiatus hernias laparoscopically, which these days we can do nearly all the time. Paper I want, this looks like 3 papers, it's one. It comes from the Adelaide group, Glenn Jameson, David Watson, and others who do a huge amount of anti-reflux surgery and use these numbers to produce very high quality randomized controlled trials. Here they've looked at tailored anti-reflux surgery. And everybody will know what that is. It basically means giving a patient with abnormal esophageal physiology a partial rather than a total wrap, the idea being you get few obstructive symptoms post-operatively. And then they've used the same cohort of patients, followed them up for 5 and then 10 years. Fortunately, the 10 years falls within my decade, very lucky that, to see how these people turned out. That's important, because a partial RAP and a total RAP accounts for nearly 100% of the anti-reflux surgery being done in the world at the moment. And their findings were there's no basis to the concept of tailored anti-reflux surgery. People with esophageal dysmotility do exactly the same whether they get a partial RAP or a total RAP, and that's an important message. I've mentioned here other authors who've shown the same thing in the BJS, trying to spread the credit, for which I make no apologies. As far as the two procedures go, partial fundoplication, slightly fewer obstructive symptoms, but a bit more recurrent reflux. But the differences are small, and the message, choice of operation makes very little difference. Do the operation you do well and you're comfortable with, which is a principle which could be applied to a lot of areas of surgery, couldn't it? Cancer surgery. Now, the next theme, Mike Griffin's group in Newcastle, a very good paper about leak after esophagectomy, made a compelling argument there's no need for routine contrast radiology, and popularized and described the use of endoscopy, which people have been very diffident about. And if I had any leaks, this would change my practice, you know. And a review. Thanks, Rob. Yeah. A review. You might think it's strange to mention a review in a talk like this, but I think a well-researched and a well-presented review can be very effective in influencing practice. This is about detailed lymphadenectomy and surgery for gastric cancer. It says an awful lot, the review. I can't go into it here, but basically the benefit seems to be the patients with the middle stage of cancer, which is what you might expect. There isn't excess morbidity and mortality, which can be greatly reduced by high volume centers and better training. And then this excellent randomized controlled trial from Korea in splenectomy and proximal gastric cancer, which showed in more than 100 patients in each arm that basically there are trends, there's no difference whether you remove the spleen or not in any measurable outcome, even if nodes along the splenic artery, the splenic hilum are involved. And this is my main paper, and like Barney, I have to confess to this fits my prejudice. This is when Derek Alston was in Bristol. Basically, they looked at patients with mid-esophageal carcinoma and did a radical lymphadenectomy, taking the nodes right along recurrent laryngeal chains around the trachea, and found that all patients who had nodes more than 10 centimeters above the tumor had nodes involved elsewhere. And there was their conclusion, there was no justification for removing these nodes. And I would say if there's no justification of removing those nodes in a mid-thoracic or a mid-esophageal adenocarcinoma, there can't possibly be any justification in the lower tumors, which we see most of the time. So the message is demonstrating a node or a group of nodes is involved does not mean removing them will improve outcome. It might do, it doesn't mean it at all. And of course, if it didn't matter, you could check all the nodes you want out, go to the neck, go to the axilla, go wherever you want. The point is that the more radical operation you do, the more dangerous it becomes. And esophagectomy is already the most morbid operation we do outside the emergency setting. In minimally invasive surgery, you can't give a talk in the last decade in esophagogastric surgery without mentioning this. 2 reviews here, very interesting comparison of open and lap management of perforated peptic ulcer, which showed that in the low-risk patients, laparoscopic was better, but for the high-risk patients, it wasn't quite so clear, which is perhaps what you might expect. Another good review, and I must say, I think the reviews in the BJS would say this, are excellent. For minimally invasive resection for gastroesophageal cancer, basically a meta-analysis of all the data. The authors made a very good point. You can only review the data that's published, and many of us have the concern about MIO, minimally invasive esophagectomy. It's the results that never get near a journal that we're worried about. But I don't want to be accused of any bias. A quote from the paper is that this is feasible, but evidence of benefit is weak. And lastly, this excellent paper from Korea on EMR and ESD, endoscopic mucosal resection and endoscopic submucosal dissection. I think there's no doubt that our colleagues in the Far East are years ahead of us in these interventions. I've just started doing EMR, should have started it a long time ago, and this paper has been very useful in setting up the practice. The paper I've picked is from Richard Beresford's unit in Exeter, who I think have been one of the pioneers of MIO. In the UK, this is their series of 77 patients operated on. All the data is there. I think, generally speaking, the data is good. The hospital mortality is excellent. But the problems in the middle there, the gastric conduit problems, the reoperation rate's probably about twice what we'd expect, and it's all down to these gastric conduit problems. The stomach and the chest going partially are all black, which is a concern. And in the discussion in the article, this is clearly admitted and conceded, and they've thought about what they can do about it. One of the ideas is this ischemic conditioning, ligating the left gastric artery at a prior laparoscopy. I think the reason I chose this paper is I had to choose one minimally invasive paper. I was impressed about the integrity and the honesty of this paper. And just at the bottom there, not so much this paper, but
this is an announcement to all delegates. The hall will be closed at 5 o'clock. Thank you.
We'd better speed up then. No, we'll still be here. Sorry.
Okay, fine, yeah. Just going to say, in terms of the reviews, there's still no evidence of clear benefit for minimally invasive cancer resection in the esophagus and stomach. And lastly, rather weakly, I've got a general group, management of spontaneous rupture of the esophagus, again from Mike Griffin's group, very, very good paper, a logarithm for surgical and non-surgical management, and the popularization of the use of the T-tube. They didn't describe it. In fact, one of the first descriptions was from a unit in Edinburgh in the BJS in 1990. Endoscopic ultrasound and the diagnosis of staging and GISTs, that's undoubtedly changed practice. Interesting paper from France, what we would call CPAP in patients having respiratory problems after esophagectomy. And every endpoint, not a randomized controlled trial, but a matched series, and every endpoint was better, including the need for formal ventilation and no increase in anastomotic leak or surgical complications, which is what we worry about. And finally, in this group, some really good quality of life studies from Jane Blaisby in Bristol and the Lagerens in Stockholm, which have shown us what actually happens to the patients we treat. Some intuitive, some not so intuitive conclusions, such as patients have less impact on their quality of life undergoing chemoradiotherapy than surgery, that patients undergoing more extensive surgery, such as open thoracotomy compared to transnatal, there's no difference. And quite depressingly, really, that quality of life after esophagectomy doesn't really improve between 6 months and 3 years, which is, as I say, quite depressing for an esophageal surgeon. The paper I've picked in this comes from just down the M4 for me in Cardiff, published only a few months ago, so it can't have changed practice yet, but I think this is an important paper. It's basically looking at what happens in real life. It's not a randomized study, it couldn't be, and it's not a clean study. These are just 417 patients managed by an MDT with potentially curable esophageal carcinoma. And you can see what they've had. 173 had definitive chemoradiotherapy, 126 had surgery, and 118 had chemotherapy and surgery. The groups are different. The patients getting definitive chemoradiotherapy would be the ones with bulky tumors, the ones who didn't want surgery, or the ones who weren't fit for surgery. Surgery alone would be ones with largely earlier tumors. And the third group is the standard OEO2 neoadjuvant chemotherapy followed by surgery. As you can see, the raw 2-year survival is the same. And the stage for stage survival, which is crucial, is no different. So, despite the clearly conceded limitations of the study, and there was an excess of squamous cell carcinoma in the definitive chemoradiotherapy group, which wasn't really gone into, but I can probably understand why that was. These data support the need for an RCT to compare surgical and non-surgical management in these patients. The authors do talk about the difficulties in performing such a trial. Nevertheless, it doesn't make it any less valid. So that's it. Those are my favorites. If I haven't selected your favorite paper, I'm sorry. If I haven't selected the paper you wrote, I'm even more sorry. That's the way it goes. Thanks very much.